everyone's watching. We are third-year nursing students from Lipa City Colleges, and today we are presenting a comprehensive case study on the Guillain-Barré syndrome, or GBS. GBS is a rare, acute, autoimmune disorder that causes the body's immune system to mistakenly attack the peripheral nerves. This results in a muscle weakness, sensory changes, and in some cases, respiratory failure. This syndrome often follows a bacterial or viral infection. Early recognition and immediate treatment such as IVIG or plasmapheresis are critical to managing GBS effectively. While many patients recover, others may suffer from long-term disabilities. Our case study is centered in a 51-year-old patient, referred to here as a patient X, who developed GBS following a gastrointestinal infection. Patient X is a 51-year-old male sales representative from Manila. 5 days before admission, he experienced difficulty climbing stairs and described a numb, heavy sensation in his feet. This weakness progressively ascended to his thighs and eventually to his arms. He also had a tingling in his fingers and toes and reported mild shortness of breath when walking or climbing stairs. He had no chronic illnesses or recent trauma, but he recalled experiencing diarrhea and stomach cramps about 2 weeks prior. This episode resolved spontaneously. Patient X does not smoke, drink occasionally, and has no family history of neurological disorders. For the epidemiology, GPS is rare with an incidence of 1 to 2 cases per 100,000 people annually. It is the leading cause of non-polio-related acute flaccid paralysis globally. It affects all age groups but is more common in males and people over 50. Patient X, being a 51-year-old male, fits this demographic. In countries like Taiwan and South Korea, rates are slightly higher due to improved diagnostics. In the Philippines, data is limited, but the pattern likely mirrors global trends. Surveillance remains a challenge due to underreporting and lack of standardized tracking. So let us now look into the risk factors identified in this case. Patient X's main risk factor was a recent gastrointestinal illness, most likely due to Campylobacter jejuni. This bacteria can trigger GPS through a mechanism called molecular mimicry, where the immune system confuses nerve tissues for bacterial antigens. Other risk factors include male gender, age over 50, history of infections, rarely vaccinations or surgeries. However, patient X had no recent vaccines, surgeries, or autoimmune disorders. In terms of clinical presentation, patient X showed hallmark signs of Guillain-Barré syndrome, such as follows. Number 1, progressive, symmetrical muscle weakness starting in the legs. Second, tingling or pins in the needle sensation in hands or feet. Third, difficulty with fine motor tasks such as gripping, absent reflexes, especially in the lower extremities. 4, mild respiratory difficulty on exertion. So these symptoms are characteristic of an acute inflammatory demyelinating polyneuropathy or AIDP subtype of GPS, which is the most common.
For the subjective data, patient X verbalized experiencing a heavy numb sensation in his legs. He reported that the weakness was progressive starting from the feet and moving upward over several days. He also described tingling or pins and needles in the hands and feet and mild shortness of breath during activity. He recalled having diarrhea and stomach cramps 2 weeks earlier, which resolved without treatment. Although he did not report significant pain, he continued to feel numbness in the extremities. Let us now look into the objective findings upon physical assessment. For the vital signs, BP 130 over 85 millimeters of mercury. For the heart rate, 96 beats per minute. For the respiratory rate, 20 beats per minute. And for temperature, 37.2 degrees Celsius. Motor strength 3/5 in all extremities with more pronounced weakness in the lower limbs. For the reflexes, absent in legs, diminished in arms, in sensation, mild paresthesia in hands and feet. Proprioception remained intact and the cranial nerves are all intact. For the mobility, dependent and unable to ambulate without assistance. So, several diagnostic procedures were done to confirm the diagnosis and rule out other conditions. So, here are the key tests patient X underwent. First is we have the lumbar puncture, which shown a high CSF protein of 95 mg per deciliter with normal WBC count, a finding known as albuminocytologic dissociation. Next is we have the nerve conduction studies, or the EMG, which demonstrated a slowed conduction of velocity. So, it confirming demyelination. Next is we also have the MRI, which ruled out spinal cord lesion. And last is the stool culture, which is positive for Campylobacter jejuni, which is the most common triggering factor, or which is the most common trigger for GVS. So, this diagnostic results strongly support the diagnosis of GVS. Now, let's understand the pathophysiology of GVS. So, GVS is an immune-mediated disorder, and it is usually starts after the viral or bacterial infection. So, in patient's X case, so it was the Campylobacter jejuni, which mimics the molecules in nerve cells, so tricking the immune system. So, it is a process called molecular mimicry. So, here's what happens step by step. So, the immune system produces antibody to fight the Campylobacter bacteria, but because the bacteria's surface molecules are similar to the components of the peripheral nerves, especially the gangliocytes, so our immune system, or the immune system, mistakenly attack the myelin sheath or even the axon of the nerves. So this causes inflammatory demyelination, so slowing down the nerve conduction or axon damage in more severe variants. And as a result, the patient experiences progressive symmetrical weakness, numbness, and impaired reflexes. So if the phrenic nerve or the cranial nerve become involved, so it can lead to complications such as respiratory failure, which may require ICU admission or mechanical ventilation. So, based on the data gathered, here are the nursing diagnoses established for patient X. So, first is impaired physical mobility related to neuromuscular weakness as evidenced by reduced muscle strength and inability to ambulate independently. Second is ineffective breathing patterns related to respiratory muscle weakness as evidenced by mild shortness of breath on exertion. Next is the risk for aspiration related to potential cranial nerve involvement and impaired gag reflex. Fourth is the disturbed sensory perception related to peripheral nerve involvement as evidenced by paresthesia and numbness. And last is anxiety related to sudden onset of neurological deficits and uncertain prognosis.
So let us now proceed to the management plan for patient X. Upon hospital admission, patient X was closely monitored due to the risk of respiratory failure and automatic instability. So the management include both medical and nursing intervention. For the medical intervention, IVIG therapy at 0.4 grams per kilograms per day for 5 days to modulate the immune response, and also avoidance of corticosteroid as they are not effective in treating GBS. So DVT prophylaxis using enoxaparin is due to the patient immobility, and also pain management and ensuring proper hydration and nutrition is important. So nursing intervention, frequent neurological and respiratory assessment is important, and also encouragement of incisive spirometry at deep breathing exercise. So passive range of motion exercise and skin care is to prevent the contracture and pressure ulcer. And lastly, provision of emotional support and clear communication with both patient and his family is one of the most important things to do. First, we explained that GBS is an immune-mediated condition where the body mistakenly attacks the peripheral nerves, leading to muscle weakness and possible respiratory failure. We also stressed the importance of early detection and reporting of symptoms like increase of weaknesses, difficulty of breathing to prevent complication. We also covered the goal and effect of IVIG therapy, which emphasizing its role in neutralizing harmful antibodies and reducing nerves inflammation for fast recovery. So additionally, we discussed the value of ongoing rehabilitation, home safety, and infection prevention as a crucial part of long-term recovery. And finally, we encourage family involvement using communication aids and support group participation to promote emotional and psychological support. Preventing GBS is difficult, but we focus on minimizing the triggering infection and early symptoms management. For the primary prevention, it includes hand hygiene, safe food practices, and avoiding contact with infected individuals. Also, a balanced lifestyle to maintain the immune health. And for the secondary prevention, it focuses on promoting recognition of progressive muscle weaknesses and sensory changes, early administration of IVIG or plasma paresis, and preventing complications like pressure ulcer, DVT, and aspiration. Although GBS has no specific cure, treatment aims to stop the progression and promote recovery. So in the patient X case, IVIG was administered promptly, and also restorative care involvement of rehabilitation therapies to regain the strength and flexibility and also independence. So let us now revisit what triggers GBS in patient X. The likely cause was a recent gastrointestinal infection. A stool culture confirmed Campylobacter jejuni, the most common antecedent to GBS. By the time neurological symptoms appeared, the infection has resolved, making antibiotic unnecessary. So the management focused instead on immune modulation through IVIG and supportive care. Patient X received the following medication: IVIG, which is to neutralize harmful antibodies, and nasofarin to prevent thromboembolism, acetaminophen for mild discomfort, omeprazole to prevent gastrointestinal ulcer, and lastly, benzodiazepine, which is considered for anxiety but caused cautiously to avoid respiratory depression.
Prevention of intervention related complication. I am your student nurse Bea, and let's look at the prevention of complication from medical intervention. Because GBS patients are highly vulnerable due to immobility and neurological deficit, we took precautions such as avoiding unnecessary catheterization to prevent infection. Next is repositioning the patient every 2 hours to prevent pressure ulcer. Third is monitoring sedation and avoiding opioids unless absolutely necessary due to the risk of respiratory depression. And last, elevate the head of the bed during and after meals to prevent aspiration. Now, let's talk about supportive management. Supportive care form a major part of our management strategy. Per patient, we implemented first anti-embolism measure, including compression stacking and positive ROM. Next, bladder and bowel program. This is to prevent retention or constipation. Next is regular skin infection and moisture control to prevent breakdown. Next is respiratory monitoring, observing vital capacity, oxygen saturation, and readiness for ventilation if needed. And last, psychological support involving family, facilitating communication, and addressing emotional stress. The third thing we need to talk about is the rehabilitation. Rehabilitation was critical for restoring patient independence. This will include physical therapy, which is a passive and active exercise to rebuild strength and flexibility. Second is occupational therapy, training for self-care, use of adaptive tools, and home safety assessment. Next is speech therapy, when needed for swallowing and communication. And last is nutritional therapy, high-protein meals and supplements to support nerve repair. Now is the pharmacology. To support recovery, pharmacologic interventions are very important. First is the IVIG. It is an immune therapy. Next is the enoxaparin, which is to reduce the DVT risk. Next is the acetaminophen. This is for fever and for pain. Next is the omeprazole. This is for ulcer prophylaxis. And last, we have benzodiazepine, which is for anxiety when necessary, closely monitoring for side effects. For our outcome criteria, the goals per our patient at discharge included: first, improve muscle strength, ideally 4 pip in major groups, unassisted or assisted ambulation, no respiratory compromise, intact skin and no pressure ulcer, reduced anxiety and good understanding of his condition, and active participation in a rehabilitation plan. And last, for the discharge plan, before discharge, we gave our patient a personalized plan, which is the continuation of prescribed medication and monitor for the side effects, a gradually increased activity with assistance as needed, maintain a nutrient-dense, high-protein diet with adequate fluids, schedule follow-ups with neurology and rehab therapies, watch for signs of relapse, which is new weakness, difficulty breathing, and swallowing. And last, educate our patient and his family about infection prevention, home medication, and support system involvement. Again, I am your student nurse Bea, and thank you for listening.